thanks for coming along, and it does look like we're going to be getting more as we go on. But we thought we should get started, and I too would like to acknowledge the traditional owners of the land on which we're meeting today and pay my respects to elders past and present. I'd also like to acknowledge those of you with a lived experience of mental ill health. Every year 1 in 5 Australians has a mental ill health problem, and it's about 1 in 6 in the workplace. So mental ill health is something, and so people with mental ill health obviously don't have the same employment rates as the general population. So 1 in 6 mental ill health is something that actually impacts on virtually every workplace and of course on virtually every family. So it's a major issue. I'll just say a little bit about the National Mental Health Commission. We commenced on 1 January 2012. The intent was to establish an independent organisation that could advise government and the community on the performance of the mental health system and on ways to improve that performance. And particularly, it was established because consumers and carers felt that their voices weren't being heard, that they were being drowned out by policymakers, funders, and indeed also by service providers. So the intent was that the Commission be established to walk with consumers and carers, but in fact to provide independent advice, which wasn't necessarily what consumers and carers were saying, but was our own opinion about the whole range of views and expertise that we could bring to the system. A couple of report cards in late 2013 with the change of government. The Commission was tasked with doing a comprehensive review of the Australian mental health system, and we reported on that, a report called Contributing Lives, Thriving Communities, and I'm talking more about that today. In that report, which is 720 pages long, it's 4 volumes, and I don't carry it around because it's just gotten too heavy. There's a 3rd volume which is about the views of, we did surveying, and we've got responses from more than 2,000 people, and it's a volume that we've done an analysis of and published, which actually uses a lot of quotes, and I'm not going to go through the quotes, but I'm just going to use them to illustrate my presentation so you got something else to look at other than me. But one of the important things about it, we had 25 recommendations, 197 actions, and it was very much a vision that's in the title of the review, Contributing Lives, Thriving Communities, that if you can enable people to lead contributing lives, which is about having a stable relationships, having stability in housing and employment and education, being able to participate in the community fully, then you enable them to lead contributing lives. And if you enable people to lead contributing lives, then they contribute to what we then termed thriving communities, and that's socially and economically thriving. And I'll come back to the economics because it's a pretty major issue, particularly when you're dealing with mental ill health and suicide prevention. But thriving communities, opportunities for economic growth, opportunities for participation and the likes. The key principles underpinning our review recommendations, and I'll go through these in a bit more detail as I go along, but people with lived experience, their families and other support people are engaged and involved at all levels, nothing about us without us. Person-centered design principles, holistic, I think that's a very fundamental one. You think it's something that the system should be about, but often it's not. It's often based on, if you're thinking about what's optimal performance of the mental health system or any part of the health system that we deal with, what's the outcome that we're trying to achieve, and often the outcome is actually defined on the basis of what's available. So what's the value, the perceived value or the demonstrated value that we've got? It's really often judged on the basis of what's available rather than what people actually need. And holistic, very important. We know that people with severe mental illness are dying up to 30 years younger than the general population, and that's pretty, due to a lot of causes, but some of it's to do with the fact that people present late, some of it's to do with metabolic syndrome, some of it's to do with the fact that if a person presents and they've got chest pain, they're often seen as a mental health patient rather than someone who potentially is having a heart attack. And then high rates of heart disease, diabetes and so forth being brought on by the drugs that people are taking. And we're doing some work on that now about a national consensus statement on the physical health of people with a mental illness, because we do believe it should be holistic and involve screening and so forth. And it's going to be a significant part of the 5th National Mental Health Plan. A new system architecture, I'll come back to step care again. Shift the focus to upstream. We're intervening too late. That's another reason why people are dying so young. we keep on doing the same thing. We wait until people get into crisis and then we intervene then, whether it's crisis in being admitted to hospital or whether it's housing crisis or whatever it might be. I mean, one of the two main reasons for people presenting at emergency departments and having episodes of mental ill health are basically about instability in relationships and housing problems. So people with a mental ill health problem are very high renters in an unstable market where you're having trouble at getting access to stable housing. So it's a major factor that we're also looking at. And then the productivity and economic growth opportunities I'll come back to. Person-centered, this is very much like a lot of the charts. Sorry, but before I get onto that, I think one of the things that's important about what we did in the review is that a lot of reviews have been done about mental health. It's probably one of the most reviewed areas you could imagine. A lot of those reviews, I think ours was different in the approach we took in that we were focused on fixing the system. So a lot of reviews are about, you've got a gap here in service, so let's drop in a new program. And so hence, you get Headspace or Partners in Recovery, which I'm not saying are not good programs. I'm just saying as you drop in more programs, you've got the states on the one hand and the Commonwealth on the other. So you're creating more silos, so the sicker you are, the harder it is to actually see your way through the system. And that having a siloed approach like that also gives that potential for greater cost shifting between the Commonwealth and the states. So how do you actually ensure that you've got a joined up integrated system rather than more silos? So we didn't focus on programs, even though our review was called that. We actually focused on how do you fix the system. And if you can fix the system, you create, and we set out a 10-year plan. If you can fix the system, you create the platform that can then deal with building further capacity on that platform to deal with different disorders, different program problems and so forth. And so that's the approach we took. Person-centered design of this, slightly different to a lot of the other ones that you see in the health system because it actually picks up on things like housing, justice, employment, education, all those other factors that determine the best outcomes that you can get to ensure that people can lead contributing lives and be part of thriving communities. The building blocks includes, of course, a whole range of things, but workforce pretty fundamental to it. And part of that comes back to what we were looking at in terms of what we recommended in terms of a stepped care approach, that at the moment we've got a system that is often very much doesn't differentiate as well as it might. And if you look at the spectrum of mental ill health in Australia, mental ill health is not one thing. It impacts on, we estimated 3.7 million people in any one year. The spectrum is very broad, mild to moderate to severe, and it may be severe in relation to psychosis, but it may be severe depression and so forth. So we don't need a sort of one-size-fits-all response to the mental ill health problems of Australia. What we tended to find was that, particularly for dealing in primary health care, a lot of the responses have been about GPs being time poor, and so therefore a lot of what happens within general practice is that people are referred on, or they're given a prescription, or they get sent to better access and so forth. So how do you actually ensure that you've got a stepped care approach that relates the response to the individual's needs or community's needs, and hence some of the steps that we were talking about. And some of these are really hard because they're about cultural change. How do you move away from one size fits all to saying, well, let's have proper digital mental health systems, for example, that people can access online services and to get the right support on digitally. And I'll come back to digital because I think it's pretty important in terms of the way consumers have shifted their focus, but the system is still catching up to them on the digital side. Very fundamental in our approach was to say, well, let's have a regional approach, again, to get away from dropping in new programs. And 3 Commonwealth departments were directly funding 542 different organisations from Canberra, well, some from Melbourne. If you took out Beyond Blue and Headspace, then the average payment to those organisations was less than $1 million. And while a lot of those organisations were obviously doing good work, it's very hard to be holistic in your approach if you're doing that. So the intent, therefore, and hence, as was described to me when I met with the 6 Victorian PHNs last week, they said, well, you've actually given us something meaningful to do, in the sense that the outcome from that has been to say, well, let's move away from, let's have the Commonwealth dealing with national programs, but to have PHNs dealing at a regional level in terms of needs assessment, planning, and commissioning of services, and let's ensure that they do that with LHNs, as they're called around Australia, or hospitals and health services, as they're called in Queensland, so that they do joint planning, joint needs assessment, and hopefully move on to co-commissioning, which is actually happening in quite a lot of places, well, a number of places now, which I'll come back to. Model proposed shift in resources, get away from the crisis intervention and shift more into prevention, early intervention, and focus on recovery. If you go on to the economic impact of mental ill health on Australia, cost is about $40 billion. It's very interesting, when we dealt with the Prime Minister and briefing him on this and getting the government response, he very quickly switched on to the mental wealth of Australia. He got the economic side of it all because, of course, mental ill health hits at a very young age. Half of it manifests itself by the age of 14, 75% by the age of 25. So the impact on productivity, on the ability of people to participate in the workforce and education really hits at a very young age, unlike a lot of other large complex diseases. So it's got a major economic impact and is growing quite rapidly. So the World Economic Forum estimates that it could be about 4% of GDP in most developed countries now. Biggest part of that economic impact, a lot of it was lost productivity in the workplace. The second largest part was, in fact, the cost to the social services system because of payments for disability support, pensions and carers payments, which are quite massive. And it's again, as I say, growing a bit. Psychosocial disability makes up about a third of all the costs of our disability support pension. Carers payments have been growing quite rapidly. That's probably in many ways to do with the fact that a lot of carers are suddenly realising they are carers and that they actually have an entitlement that they hadn't been taking up. But big strain on carers as well. And the NDIS isn't helping that, which I'm happy to talk about. So the government response, 26 November last year, pretty well endorsed the directions that we were heading in, and so I won't go through those in details. This will be available to you. But it was very much about national leadership from the Commonwealth and then giving responsibility out to the PHNs for regional coordination and planning. So they've bundled up 7 programs into what supposedly is a flexible fund. So ATAPS, Mental Health Nurse Incentive Program, MISRA, some suicide prevention funds, some additional money for Aboriginal and Torres Strait Islander mental health and social and emotional wellbeing, a few other programs on top of that. They call it a flexible fund. There's actually not necessarily that much flexibility in it at the moment, but I think over time that flexibility will grow. My view always on flexible funds, because I've had to deal with them a lot at the Commonwealth level, is that the finance department likes to call them flexible because they're flexible for them, not for us. But there will be, if we can get it right. I mean, it's very interesting because I think mental health for a change is at the vanguard of leading reform in Australia, that focusing things down to a regional level and giving the potential for greater flexibility at that level does actually mean that mental health and PHNs and working with their partners and hospital and health services and so forth have the ability to lead change that I think will then, if you're successful in it, will then lead on to other programs and services being devolved to that level rather than being run out of Canberra. And I have I don't know whether you know Lutz's laws on integration, but I think there's now, he started with 5, I think he ended up with 6. One of the laws that I always liked was that all integration is local. And I think that's true. I mean, I can work across portfolios at a Commonwealth level and then try to do the intersectoral stuff and work with the states and territories, and we can all agree on things. But does that translate into action on the ground? No. It's actually about people like yourselves making things happen on the ground. I mean, to put Lutz's law into context, I tend to say that, well, the further you are away from the problem, the less likely you are to come up with the right solutions to that problem. So it is actually about local solution making, it is about local decision making, and that was hence the intent of pushing things to this level. So, you know a lot of this, services to be commissioned, not delivered through PHNs, coordinated packages of care with severe and complex mental needs, and I think that's an important one. It fits in with the primary health care advisory group reforms that looked at a healthcare home, which I'll come back to, but it does give the opportunity for bundling up payments and putting things together, and then a bit like how the NDIS is supposed to work, to actually put in place packages of care for people, particularly with the more complex needs and with comorbidities and so forth. A new approach to suicide prevention, I will touch on that and acknowledge that fact that in fact you've got high rates of suicide within this PHN, and in particular in some communities. And we previously, under the National Suicide Prevention Program and the Taking Action to Tackle Suicide Program, which are the two main Commonwealth ones, there was a sort of a thousand flowers bloom approach. There were some really good examples of suicide prevention programs being put in place, but it wasn't joined up, it wasn't integrated. And so the intent is very much about, and this will come out in the 5th National Mental Health Plan as well, that the intent is very much about how do Commonwealth and states and territories, the PHNs and hospitals and health services work together to put in place co-designed models of suicide prevention which are developed with the community, with consumers and carers, those with lived experience. And how do you use that funding, which isn't all that much at the end of the day, but use it as leverage to engage with the private sector, with business, with the local government, with local community organisations, be they clubs or churches or whatever they might be, to come up with co-designed models that can then be implemented to prevent suicide within communities, and of course monitor and evaluate the impact of those things. So it is about that local ground up, community development type model was the intent of the changes in suicide prevention, and as I say, that'll be reinforced. Changes to the Headspace model, the intent there was if you're going to go to a regional approach, then there's no sense giving a huge bucket of money to Headspace National in Melbourne and having them determine that this is the model that will apply in particular localities. So it was to give flexibility at a local level so that you had Headspaces working with child and adolescent mental health services and the likes. Some places it already works very well, and some places they're over the road from each other and they don't talk. So the intent was, again, about that regional approach. Now, there's some boundaries on how that might occur and some changes that happened in the election, so that may change somewhat, but the intent, I think, stays the same in terms of the regional approach. An integrated Aboriginal and Torres Strait Islander mental health and social and emotional wellbeing services, a very important part as well. So there's some additional funding that came through there, and we worked very closely with a number of the national Aboriginal and Torres Strait Islander groups to come up with the design of what we were recommending there. The single digital gateway, I think that's an interesting one because a gateway, the intent very much was to say we don't want a digital gateway that's going to duplicate what exists, and you certainly don't want to put a digital gateway in the front of Lifeline, for example, if people are ringing up in crisis. However, it is very hard for people to navigate the digital system at the moment. Do they know, for example, that if you ring the Butterfly Foundation, you can get advice on eating disorders? So how do you join it up, have common platforms and linkages and so forth? But to move away from just digitising what currently occurs and having digital applications, which, they're growing and expanding quite rapidly, so you can do biometric modelling and biometric approaches whereby your information is sent back to your general practice or to your AMS or whatever it might be. So there are a whole range of ways that you can use digital information, but in many ways it's actually about transforming business. Consumers are getting online, particularly young consumers, and they're using applications and websites from around the world. We have some great ones in Australia that are used by others from around the world. So how do we move from where we are now to incorporating digital systems change into everyday practice so that it's not seen as something separate but as part of a person's care plan and so forth. Because people can look at their information. If you're in a lot of the parts, if you're in various systems in the US or in the NHS, as soon as you see one provider, your information will be recorded and will go online, a bit like my health record. Is supposed to work over time, and everyone will have the access to the same information according to what's appropriate. So you're not then dealing with your same information time after time, and you're not seeing one provider having different information to another provider. So it's actually how you have a systems approach to digital. Am I going the right way? No, I don't think so. I'll try that again. What I'll get on to give us time for a chat. Healthcare home I've touched on. The intent is really to ensure an accountability there, so that, and again, it links into what's happening digitally. It links into the My Health Gateway, My Health Record, also into the potential to establish a single care plan so that everyone signs up to the same care plan, so you each know what each other's responsibility is. But it's about a responsibility and accountability through voluntary registration system. Workforce, key enablers for PHNs. I think some of the key enablers, key challenges, sorry, for PHNs is fundamental one is about defining value, which I touched on earlier. It's not on the basis of what's available now, but it's usually value is determined by the customer or the consumer. Now, the customer or consumer, the consumer of a service, we all interface with each other. So who is the consumer that you're dealing with? That might change over time. But at the end point, the consumer are those who actually need assistance in relation to mental health or suicide prevention. So how do they define value? What actually matters to them? And at the moment, I don't think we're actually doing that really well in terms of looking at outcomes and so forth. Key challenges, building trust and mutual respect. I mean, there's a lot of concern, I suppose, being voiced about how things might change, but reality is what we're doing in mental health through PHNs is a change management program. So if you're going to be commissioning services, then that potentially means you're going to be decommissioning other services. So how do you get the balance right between getting people concerned about their funding future and the fact that you do actually want to change things? And you know, to start off with, I wouldn't be suggesting that we're going to be seeing massive change over the next 12 months, but that over time, if we keep on doing what we're doing, then really the reforms haven't really been worth doing. So it is about incrementalism, but also progressivism over time. So how do we actually make that happen? Engaging with those with lived experience, their families and other support people, fundamental principle. Smart commissioners. Commissioners isn't about, being a commissioner isn't about how you procure services. Again, if we just procure things, then we won't have moved very far. Commissioning is actually about that needs assessment process, and it's good to see in the work that's been done up here on your health needs assessment. It's then going on to establish the market. So what are the services that need to be provided? If those services aren't available, then how do you commission services so that you do, for example, practice development so that a practice can provide the services that you want for the community rather than simply say, well, this is all we've got, so this is all we'll provide. So commissioning is about developing the market so that you've got the services available locally that can meet the needs that have been identified. So an important part of what we're looking at. Regional equity, major challenge, particularly when you're dealing with workforce because of the difficulties of distributing workforce. But you can look at quality and standards. I mean, not everyone can expect that they're going to have a psychiatrist living in their community, but you can actually look at the quality and standards of the services you're providing and ensure access through other things such as digital approaches, and focusing on those with high needs, fundamental. I think one of the important things is that we were focusing on was going beyond diagnosis to focus on functional impairment. So what's your functional capacity? And again, a lot of it, you can have the same diagnosis but have totally different functional capacity, so that a person with depression, two people with depression won't have the same functional capacities. It'll depend on your ability to participate, so which gets back to your ability to lead a contributing life and what are the things such as housing and employment and so forth that enable you to do that. So while we've got the opportunity for partnering between PHNs and hospitals and health services, what we do need to move on is how you partner them with those other services, those social services that support people to lead contributing lives. And I'll give an example. A person with a mental illness, we've got high rates of people with mental illness in jails. What happens on their discharge from jail? Have they got housing enabled for them? Are there people there to support them to actually get them into a house? Or are we going to just see the cycles of homelessness and cycles of getting back into crime and so forth? So how do you prevent that recidivism? And a lot of it won't be about health. So how do you connect as a PHN with those other services that are available to ensure that you do have that holistic approach to the functional capacity of a person? And the other ones are quite logical in terms of establishing the investment logic. As I say, we touched quite a good base with the Prime Minister on the economic wealth of the nation, and so we're doing further work on economic indicators so that we can demonstrate more rapidly that in fact the things that we are doing actually are having an economic benefit in terms of productivity and growth and so forth, which is very important with governments in times of scarce resources. So I think it's a good argument to make. But very much about how do you demonstrate the effectiveness of what you're doing, so monitoring and evaluating what happens. Australia's not actually been very good at monitoring and evaluating and providing evidence and sharing that evidence. I do think we've got the opportunity now because we're looking at more of a one health system type approach with what we've done in terms of the reforms. So getting the Commonwealth out of what the states do at a local level as much as possible, although I know from those working within the PHNs, you've got a lot of performance indicators, a lot of which are about activity and not really about outcomes, and hopefully we'll build to outcomes over time. Effective use of the mental health workforce. It's about actually ensuring that we do have a team-based approach, so multidisciplinary approaches, but also enabling people to work at the top of scope of practice, so that we do look at greater use of peer workers. We have a shortage of mental health nurses. The work that's being done up here on the growth in the number of Aboriginal health workers, I think, is fantastic and a good model for elsewhere. All those sort of things are important. The use of digital technology, because you're not going to get people at a local level, but then connecting with your sort of first frontline, first responder type level, particularly when you're dealing with suicide prevention. Dealing with peer workers, I mean, people discharged from hospital after a suicide attempt or self-harm, do they have a peer worker who can support them in the community to make sure that they, in that next critical 7 days, for example, they don't actually commit suicide or attempt again. So those sort of things where we join up the workforce and identify the potential different levels of workforce that can deal with those types of issues. So ultimately, and I've done that pretty quickly because I wanted some time for a chat. Basically, we're going to continue in our role. We've been assigned to continue to monitor and drive performance of the reforms, but also report on performance of the mental health system and suicide prevention systems overall. And that's very fundamental to where we're coming from, because we are actually very committed to the contributing life, thriving communities concept. But the reality is, to make it happen, it's really very much over to you. Thank you. Happy to take questions. Comments? Hey.
Hi, David. I'm Jeremy Orts. I'm the CEO of the Mental Illness Fellowship of Queensland. We work across the whole PHN footprint, actually.
Good.
And one of the big picture issues that is becoming very clear is around the resources that are going towards the NDIS, and I'm talking about federal resources, and the resources, again, federal resources going into the PHN, so targeted at mental health. What we're seeing is a reduction of the ability to fund social supports that are so important around homelessness, alcohol and drugs and so on. I wonder if you'd like to make a comment on that and what the National Commission's view is.
Yeah, I mean, the Commonwealth, because it's bundled up those programs which they regarded as all health programs, and this is the PHN side of things, their focus has been very much on the clinical side and what do you do to support general practice and the sort of integrated care pathways between primary sector and tertiary sector, secondary and tertiary sector. They are freeing up a bit in their language on that, but I actually think I think that will take time. But they are actually in their language in the guidance that's being given and in the 5th National Mental Health Plan, which hasn't come out yet as a draft, but will. They talk very much about how the PHNs need to work as linkers and joiners with all those other services, so they take them all into account. So, and I think a lot of the PHNs are actually quite attuned to that, yeah. But there has been a pushback, and Mental Illness Fellowship of Australia has been very much at the forefront of saying, well, hang on, psychosocial supports are the areas we're going. I think the bigger problem, most immediate problem at the moment is what's happening in the NDIS, because we've got 65,000 people who supposedly, I mean, Productivity Commission said, I think 57,000, but population growth, the work we did said 65,000, who potentially are going to be eligible for NDIS Tier 1 packages. The numbers coming through aren't demonstrating that's necessarily so, but you've got a situation where governments have said, well, we're going to put all of our community mental health support services into the NDIS, and at a federal level that's things like FAMS and day-to-day living and PIR, whereas a lot of the clients in that area may not go into the NDIS. So our position has been very strongly that the money should follow the client, that if a person does transition into the NDIS and a package, then fair enough, the funds should follow them. But if they don't, then the funds should stay where they are and be used to support them elsewhere. However, having said that, the Commonwealth actually recognises that there may be a gap there for certain people, and they're doing Department of Social Services is leading a review next year of what's actually happening in the transitioning, because it's 2018 for most states now, 2019 for Queensland. So they're doing a review next year to see actually what's happening on the ground, and do they need to provide more funding. And one of the options they're looking at is, should they provide funding packages to PHNs to support those people who do not transition but otherwise would have been supported, which I think is okay for the existing ones. But if you're a future person who may have been eligible for PIR and you're not now, and you don't get an NDIS package, then what happens with those ones? So I think there's a long way to go, and we need to be very vigilant in what we do about it.
Yeah, and similarly, you mentioned carers and family earlier, and the increasing gap there around provisional services.
Well, because the NDIS is about the individual. I mean, carers can be part of a package, but they're not necessarily going to be a part of a package. So what are the Commonwealth and the states doing about supporting carers where, if they're not included in a package, and obviously they may have been de-skilled over time and find difficulty getting back into the workforce, what are they doing to support those people to get the skills they need and to live, again, contributing lives? So I think they're big questions that have yet to be answered.
In our PHN recently, we identified that ATAP services cost about $260 a service. We clearly identified that using better access at $80 a service and topping them up with some ATAP's money at $40 or $50 a service would probably skyrocket the number of psychological services we could provide and halve the cost per service. To what degree does the PHN have flexibility in using ATAP's money?
Yeah, I'm not the Commonwealth Government, so I can't really answer that. We provide advice which isn't necessarily followed, but generally has been. Bernie might be in a better position, but my understanding is that the idea of actually having a flexible fund is that you bundle up things like ATAPs with MISRA and mental health nurse incentive program and so forth, and that you should, even if not immediately, because I don't remember how long it's for, you should over time be able to get that flexibility to purchase alternative services or additional services. But others might know the answer to that better than me. It should be a local decision-making process.
And I think just to add to that, I don't know in detail, Rod, but it's two issues. One around the economics of those two programs. The other is the distribution, the access for people. Is the other big ticket items, and that we need to work on through that recommissioning process.
Yeah, and I think that if you look at, frankly, the distribution of what's happening under better access, it's still very firmly focused on metropolitan areas, regional centres. It's not actually, and part of the reason for ATAPs was to give that ability to commission services outside, or purchase services outside of those areas, because the distribution, for example, of clinical psychologists is worse than that of GPs when it comes to rural and remote areas.
I mean, the MBS and the PBS are the two biggest item numbers there, which of course the Primary Healthcare Network has no control over. And the reason why people don't access better access is because they can't afford the part charges. So one of the criteria for ATAPs is that your circumstances have changed, so you can't afford it. But it's often a little bit too little, too late for a lot of people. So my interest is at the more pointy end, at the acute end, where we start to see people present, particularly as young people, the sub-threshold in terms of meeting criteria for a diagnosis until they hit age 18 or thereabouts. But when they get there, they've had a trajectory of often dozens of emergency presentations, involvement with child safety, involvement with youth justice, a whole range of services. And then what our acute services then do is try desperately to then engage a bulk billing GP to undertake a mental health plan, again MBS, to refer to a hypothetical bulk billing better access provider. And they're very few. The few that we have got are at Headspace and other sort of agencies that have tried to cobble together something out of those particular programs. So I think that's the big issue. I mean, and that sort of structural change, something you could do really simply. I assess somebody in the emergency department or a psychiatrist or a registrar in tertiary services. Why on earth could we not refer to better access if that program's going to persist? But furthermore, there's a dose problem here as well. by the time you get to that point, you're dealing with largely really traumatised people that need continuity of relationship. The trauma-informed care is where you have that continuity. And you need to revisit therapy repeatedly over the course of a person's life or trajectory if you're going to make any difference. So we're not talking 2 sessions of motivational interviewing, to address their problems. And it's enormously frustrating in terms of workforce. We've got very skilled workforce, but we don't have the structures that enable them to actually work to their potential or their capacity.
Yeah. Well, I think a couple of things on that. I'm not disagreeing with you at all. Part of the reform agenda, if you look at the primary healthcare advisory group recommendations and the healthcare home stuff that have been agreed to, is to say let's look at bundled up payments, which may include, for example, and which we included in our recommendations, which may include things like better access payments where they're not available in an area, for example, being bundled up into a package that can be bought. So I think the opportunity is there. The trial the Commonwealth's looking at is 65,000 people over 200 practices. It'll be interesting how that actually goes. I mean, it's a pretty well-established approach in New Zealand and the UK and the US and so forth. So, but that's what they're looking for in terms of freeing that funding up so you can do that. I can't remember the second part of your question or your comment.
Maybe it wasn't a question.
It wasn't. I don't think it was. I don't think it was.
But it's how we've got these
Oh.
non-joined up beds.
Yeah,
A
but
working ED, we can cost somebody
Yeah,
to come in for 250,000
Yeah.
a year. But we can't provide one session of therapy.
yeah.
We can provide 250,000 crisis intervention, or bring someone down who's homeless from the cave at a cost of 30,000, which is what it costs the RFDs to bring someone down and take them home. But we can't actually provide them a house. It's crazy stuff.
Yeah. Yeah.
We
It's a
actually
comment.
have the workforce up here. We have the psychological workforce, but the system stops it from being used.
Thanks, Ron. Just had a question from Alison.
Yeah, my question is around telehealth and the access that people have to it in rural and remote areas for being able to access allied health professionals and support. And is there any scope where that's going to be rebatable, where people can use that better access? Do you know anything that's going to happen?
I've got no idea. I mean, they've resisted it for a long time, as you know. Yeah. So, yeah. But again, if you went to a bundled payment system, you could actually do it. I mean, I think the concern has been more about how do you manage a fee-for-service system on that basis.
I can probably help a little bit there, Catherine, and PHN. We actually we do have a telehealth hubs in certain areas, and we're looking to expand that and also support allied health professionals in the utilisation of those. So if I can get your details afterwards, I can certainly pass them on to Cathy. And what we're doing is trying to encourage that innovation.
But I think the question was that it's not relatable for
Yeah.
allied health professionals.
Yeah.
We can provide a service, but their clients don't get the rebate. That's the issue. It was mentioned in another session this morning. There's no answer to it at the moment.
Yeah, under current ATAP service provision, we do allocate funds for that. But going forward, that is something that we will be taking into consideration with the development of the step codes.
Just had 2 questions, just up the back first, Kate.
Just following on,
Yeah.
sorry, on that same topic,
Yeah.
under MISRA in the northern region, we've recently funded a pilot program of video psychology for the RA4 and RA5 area. So I'll happily talk to you about that.
Good.
David, first of all, I'd like to congratulate and commend you on undertaking that big review and putting out that you were going to try to fix the system. So the first general question is, I guess, how confident are you that that will actually occur and that all your recommendations, well, not all, the majority obviously get implemented?
Well, I've worked with governments on and off for quite a while, and I've actually never seen a government response so positive about supporting recommendations of an independent inquiry. I mean, often they shelve them, they disappear or whatever, but they actually endorse most of the recommendations and are putting in place some of the steps to get there. I think there was some. It's a question of how far you go, because I mean there's a lot of community support, consumers and carers service provider support for what we recommended, and basically an issue of get on with it. The issue is always in the implementation. So I'm reasonably confident that we're heading in the right direction. I do actually think it'll be things like how well do the PHNs advance the agenda that's going to be very important about what steps will be taken next. So I've got a reasonable level of confidence. I mean, there've been some trade-offs made, but they have been willing to take on some fairly entrenched circumstances, and you might have, yeah. So look, I've got a reasonable level of confidence, but it's going to take some time. I mean, this is not a sprint, it's a marathon, as I keep saying. It's going to be a long haul, and it'll be issues about demonstrating effectiveness. I mean, can we demonstrate that anything that we're doing in terms of systems reform and structural reforms have made one iota of difference in anyone's life? So, it's very much about how you demonstrate that, in fact, things are getting better. But you've then got so many variables, like things like levels of funding and so forth, which, can impact on that, of course.
If we just make a quick comment about the steps care model. I guess I read the recommendations, and I guess it links in a little bit to one of the comments from one of the consumers around the time for GPs. And I guess in the step care model, the GP become much more part of the mental health care planning and I guess reviewing. And I just, in terms of the region that I work in as director of mental health, I can't see how GPs would invest or even have more time to do that care planning. Get them in, say you go to new gym and do that, come back and do 1 week and we'll see how you make progress. If not, I'll send you this way. And I guess just for the PHNs as well, I guess to consider that it's not an easy task. And the other thing, from my understanding, with the increased access to psychological therapies in the UK, what the step care model did was increase throughput. It actually didn't increase quality or improvement in the outcomes. And the third part of that is, I guess, the recommendations was, not everyone needs face-to-face. I mean, certainly, I embrace change. Change has been happening for 3 or 4 years. Seems to be the norm in mental health. But what Richard was saying yesterday, most people actually do want to have that face-to-face, that engagement, that being heard, understood, validated, listened. I guess it sometimes seems to be a very theoretical approach to something that doesn't necessarily translate into...
Yeah. I mean, if you look at the step care model, in fact, the first step of it is very much about online without going to a GP to begin with. So it's about people seeking their own assistance, and so therefore part of the importance of the digital gateway is to actually provide people with access to sites that have got an evidence base, because we've got lots of sites, massive numbers of sites, but do they have an evidence base? Your point about, and Richard could probably comment on this better than me, but people wanting to bond with people, the story that Richard told yesterday about people walking out on the Golden Gate Bridge. I'd heard that many times, that if someone had made eye contact or been friendly to them, then they may not have jumped. So I think that's true. What I think the evidence is showing, that in my knowledge of it, is that online works generally as well as face-to-face, but it actually works best when it's when it's guided. So you are actually dealing with a human being, and it is being followed up, and you're not just doing things in isolation. Yeah, and your point about GPs, I actually think the first step is probably the hardest, because it is major cultural change. So and that's not just for health practitioners, it's also for the community, which wants to go to a GP and get a prescription and all the rest of it. So, and how you do that in a safe way is obviously always, it's going to be something challenging over the next few years. You don't free up GPs' time so much at that level. No, the intent was more about the healthcare home model, where you can provide bundling that will enable, for example, mental health nurses or practice nurses or allied health professionals or Aboriginal health workers or so forth to work with people.
I just wanted to add to the voice that Richard spoke to. It's a voice for another group of people that is the long-term dysfunctional through the mental health unit may or may not get some sort of case management. That group of people needs that same 2 to 3 years of face-to-face therapy, the therapeutic relationship, that coupled with the psychosocial and all of those other needs, actually again stops them from continually returning to the mental health unit. It doesn't take a lot. They're not 10 sessions with better outcomes is useless. 8 taps, they're pointy ends, so they exceed the mild to moderate. That group who are not going to get into tier 3, probably NDIS, who's going to look after them now? Who's speaking for them? You know, and this is a group that I feel PHN really needs to get a hold of.
Yeah, I agree entirely. I mean, one of the things that we discovered, and it may not be such an issue here, is that we do have sort of what we identified as a missing middle, that, you know, you're either in primary health care or you're in crisis, and there's nothing in between that is actually supporting people to live in the community. So yeah, I agree entirely with what you're saying, but yeah.
Yeah, just a very quick question. Just in regards to the setup of the PHN, how do you see consumer and carer participation within the primary health network itself?
Well, in principle, we'd see it as, I mean, you can have different governance models, and when I talk governance, I'm not just talking a board, I'm talking structures in different parts of the organisation. I mean, obviously there's community advisory councils that were part of the establishment that I think were obviously an important part. I get back to, if you're going to really do it effectively, and, you know, it applies for everyone, but also particularly in Aboriginal and Torres Strait Islander communities, you really need to be doing co-design of services. You then need to be looking at how you sort of co-develop those services. What are the models that are going to be put in place? How do you build the market? As I was saying earlier, I mean, people don't necessarily like the term market, but it's actually about how do you build the level of service. And then I'd be looking at co-commissioning. How do you engage them in actually commissioning services, ensuring quality, ensuring their involvement, and then ultimately their role in monitoring performance. I mean, what are your indicators that people actually, their experience of service, but also, you know, did it improve their lives? So I think it applies at all levels throughout the system.
Probably going back a little bit to Phil's question about general practice and healthcare home. So I would hope that it becomes possible that general practice just doesn't mean doctors. It means a primary care team. Because when you're looking at mild to moderate distress, which is the high prevalence disorders, most of those people don't need a doctor. Just like healthy women who are pregnant don't need a doctor. So competent nurses, allied health professionals can look after someone through their journey, and they don't want to work outside their scope of practice. And if somebody needs a doctor, they'll say, you need a doctor. Yeah. But the whole system is so, I am a doctor and I'm a psychotherapist, but the whole system is so doctor-centric, and I don't think it's leading to better outcomes.
I agree, and I think I generally talk about general practice. I don't talk about GPs as much. But yeah, I mean, yeah, 50% of people with a mild illness will recover within 3 months. We are putting people on, we're second highest users of antidepressants in the world. The only country higher is Iceland.
For every adult in Australia, 1 in 10 adults in Australia.
Yep, 10% of the population.
Are antidepressant every day.
Yep. Yep, that's right.
There's no evidence that they work for mild to moderate depression.
No, and when they come off, are they any better? So no, I mean, we have tended to medicalise distress in daily living, yes.
Can I just say one thing about the prevention, or a question about prevention? So there's a lot of mention about primary prevention in the document. You know, that's what everybody wants: early intervention, and where do you intervene? That's the thing. I mean, I would say the majority of people that develop mental illness and who end up becoming really heavy service users of the health system in all sorts of ways, the common denominator is adverse childhood experiences and an accumulation of those. So early intervention then is actually making for a nurturing, nourishing environment for children to grow. Children need to be safe, they need to not have these adverse childhood experiences, and when they do occur, we need to quickly provide some sort of response to mitigate those adverse experiences. I cannot see, you know, despite all the rhetoric, that we're intervening anywhere near upstream enough or downstream. I forget which way it's flowing.
So in the review, what we did is we, you know, stratified populations on a couple of bases, but we did actually look at different stages in life. The 2 areas that we thought were, I mean, you could say all areas are underdone in terms of, you know, support and focus. The 2 main areas that we said were most relatively underdone was child development and also what's happening as people age, that we're not looking after our older people as soon as they get into mental health difficulties. And we've got high rates of suicide there as well, of course.
Yeah,
so the child...
In the 40 to 45 age group,
yeah.
who have the most adverse childhood experiences?
Yeah, well, yeah, and that's why we talk there about joined up support for child mental health. The fact that, there's a push around the number of countries now about focusing on the first 1,000 days, which are from the point of conception to the age of 2, which actually works out about 1,000. And we would be saying the same thing, because if you look at 80% of people who end up in inpatient or outpatient mental health services, 80% of them have had child abuse. So yeah, agreed, huge priority.
Well, thanks everyone. Can you put your hand together for David?
Thank you. Welcome.